I'm not sure that it was operational friction that caused it.
How do you deploy AI across so many practices without triggering fear?
Over 3,000 clinicians in the business is clearly a challenge.
AI is a second opinion, not a surveillance tool.
We even went down to the minutiae in terms of speaking to the indemnity providers.
Do you think AI makes corporate dentistry structurally stronger than independence?
I think that ultimately this is a new operating model.
One metric that will define the highest performing DSOs. This is the TechDental podcast, the strategic intelligence hub for leaders shaping the dental industry. We break down how AI, data, and operating discipline drive performance and scale. I'm Dr. Randeep. Let's dive in. Today's episode is a landmark conversation. We're examining what may be the most significant AI rollout in the history of UK dentistry, the strategic partnership between MyDentist, the UK's largest dental organisation, and Overjet, the global leader in dental AI. This is an episode about systems. We're exploring what happens when AI moves from experimentation to infrastructure across a large national clinical network. Joining me today are Dr Nyree Whitley, Chief Clinical Officer at MyDentist, and Dr Gordon Barfield, Senior Clinical Manager at Overjet. Thank you both for being here today.
Thank you too.
Glad to do it.
Nyree, what operational friction clinically did you notice that made you think AI needs to be introduced into this organization?
I'm not sure that it was operational friction that caused it. It's just about progression, isn't it? And with regard to utilizing all of the tech available just to assist our clinicians, everybody can benefit from some support, but this is certainly not to replace any operational or clinical friction that we had. It's very much as an assistive diagnostic tool.
And how do you deploy AI across so many practices without triggering fear, resistance, or erosion of clinical confidence?
Clinical change management across that many practices and clinicians, we've got over 3,000 clinicians in the business, is clearly a challenge. But we have a very large, in fact, the largest clinical support network of anywhere in the UK. So what's super important is that we have clinicians that will introduce this to our clinicians. And exactly the same from the Overjet perspective, they have a very strong clinical team who will help with regard to the training of our teams. So we will start with introducing the fact that we're going to go with a tech, and we explain to them why we've chosen Overjet as a partner, and I'm sure we can get into that later. So we then we ask for hand raisers. So who's interested? We did it at our clinical conference this year. So we have our clinical development advisors who are dentists that work for the business that support our clinicians. They want to be involved. We then have other clinicians that say, fantastic, that sounds great. I'm really keen on being involved in this in the first instance. And we start off with that layer. So we train them, we educate them. They then help to engage the next layer down. So it really is a layered waterfall approach, very much with clinical evidence, but actual clinical support backing it up.
It strikes me that adoption at this level is not just a technology decision, it's really a governance decision. Gordon, from your perspective, what must exist inside an organization before AI creates advantage instead of creating noise?
Randeep, I think there really are three key elements here. Clinical alignment at the leadership level. As Nyree mentioned, we really can't deploy AI as an AI project solely. It has to be owned by the clinical team and the governance team as well. And that's something that MyDentist understood very early in this cycle. I think point number two would be around data maturity, clean imaging protocols, very consistent radiograph quality, and shared definition of disease. And then the third thing I think is perhaps the most important bullet, which is psychological safety. Our clinicians really need to feel that AI is a second opinion, not a surveillance tool. If those don't exist, AI just amplifies inconsistency. But when they do exist, it becomes a real infrastructure and a force multiplier.
What's a common mistake that you've seen when DSOs roll AI out too quickly? What can break first if that happens?
Yeah, that's really a good one. I think treating it like a feature launch or an IT injection, if you will, instead of a behavioral shift, there is a change management process that has to be assumed here, has to be dealt with. And then another mistake is focusing on activation metrics. In other words, how many practices are turning it on or using it, rather than the clinical calibration around the tool and the education that needs to occur to be able to use it in a collaborative method. AI changes how clinicians see, discuss, and defend their diagnosis. And that really requires case review, clinical work, peer discussions, governance pathways for agreement as well as disagreement.
That brings us quite naturally to the dental surgery itself, because scale is quite abstract until it touches the chairside experience. Gordon, you've spoken about clinical alignment as a North Star. When two clinicians review the same radiograph, what does alignment actually look like in practice?
I love that question, and I think it's more what it doesn't look like. Alignment doesn't mean complete agreement, right? That we're still going to have disagreement because we have our natural tendencies. But it means that they see the same anatomical landmarks, as an example, on the x-ray, the ground truth, if you will. They can use the same threshold definitions and articulate why they disagree clinically based upon an objective piece of information. And most importantly, it brings these two closer to a shared truth. And I think that's perhaps, the most beautiful thing that AI provides us clinically, being closer to that shared truth.
Where is the line between assistive intelligence and decision displacement?
I think that's actually really simple, Randeep. AI informs the clinician, and the clinician at the end of the day decides. If the AI auto-diagnoses without review or suppresses, let's say, clinician disagreement, or even penalizes deviation, as an example, then we really have crossed that line. At Overjet, rejection of these findings and these AI suggestions is not a failure. We don't see it as a failure. We see it as clinical calibration. If a clinician overrides, they're actually helping with training data and governance signals that are very important for the future of this technology. So I think AI really should reduce the cognitive load for clinicians, but not reduce clinical authority.
One of the promises of AI really is reduced cognitive load, not additional pressure. Nyree, from your vantage point, does AI reduce diagnostic variability, or does it simply make disagreement more visible?
I think it reduces variability because it's like having another clinician to discuss the radiographs with. We know that if you give a group of 10 clinicians a set of radiographs, or clearly a patient to examine, that they will all come up with slightly different treatment plans and perspectives. So I think it's just that support to make them think, to confirm what they think, or actually to make them question their own interpretation of the radiographs, which is a really healthy thing. And that's development, isn't it? It's progression.
Nyree, have you seen a moment where AI has genuinely changed the clinician's mind in real time?
We have only started adopting it in the estate, but I went over to the US and attended some of the practices where it was being utilised over there. And it does, I don't know about changes the clinician's mind, but it will just reaffirm in clinician's mind where possibly they had doubts before. I have not seen anybody make a complete U-turn based upon the AI. Patients, that's where you get the U-turn. We've all had patients, I'm sure you have, Randeep, where they say, okay, we will tell a patient, look at these radiographs, and they can't really tell what they look like, even though we try and point it out to them. We say, you need a filling here, and they say, I'm not having any problems, so why do I need it? When you show that patient in an illustrative way, so in a visual way for the patients, that's where you get the U-turn, is in the patient's mind, not in the dentist diagnosis.
I think the patient education piece is really critical, and this is where AI comes into its own. And that's a whole other question there, and it's an important distinction to make. How do you train clinicians to use AI as a second opinion without deferring authority to it?
Part of that is done with the support of Gordon's team and with the experience that they have with regard to using AI. And it is telling them to utilize it as a diagnostic aid. It is not there to replace themselves. And we've been really clear with that, because actually clinicians don't wish to be replaced either. And I, as a clinician, don't particularly want to be replaced by robots and AI, a deep fake version of me working on my patients. That's not really what we want to see. So there as an adjunctive tool.
I think the whole AI replacing jobs, especially clinicians and all this doom and gloom, is a little bit overhyped. I see it more as transforming the job and having it as a second opinion and actually freeing up the human to do what they do best, which is the patient-centered stuff.
Makes you think, doesn't it? It's like having a debate with somebody over an opinion that you have. You can you can take on board their views, but then you are still responsible for deciding which direction that you go.
Once you introduce analytics, you also introduce measurement, and measurement changes behavior. Mm-hmm. So, Nyree, there's always tension between performance data and clinical autonomy. How do you prevent analytics from becoming surveillance? And I think Gordon briefly touched on this earlier.
Whether we like it or not, as clinicians, we are monitored, if you like. We all have clinical audits at least twice a year. If you work within the NHS, there are the NHS red flags, but actually they are all seen in a positive light because actually they can check on your clinical quality and standards and can help you to improve. And actually, if you are falling slightly below the expected standard, you either have an opportunity to explain why. For example, your practice may only be in endodontics, and maybe that's why you don't take pipe and radiographs because, you are confined to an endodontic practice. But the autonomy is always going to be there. But as Gordon referenced before, it is an educational tool. So if and when we did see people that were falling well below, it's like anything. There are expected standards and we will deviate from those at any one time. But if somebody's falling well below, it is just a pointer for us to go and see, okay, let's go and have a conversation with that clinician and try and understand why they're falling below or do they need any support? And that's where it's super helpful that we have that clinical support team of very experienced clinicians to go in and help them.
Gordon, did you want to elaborate on that piece at all? In terms of the software itself, is there an inbuilt feature there that flags up variations? How do you highlight that within the software itself or work with clinicians?
Yeah, absolutely. I think one of the things that artificial intelligence is really good at doing is uncovering that built-in lack of objectivity that we have always had in dentistry, right? We oftentimes don't agree when looking at the same set of diagnostic data. And that can be a problem because it can be confusing for patients. It can be confusing for our team members. AI provides an objective standard that we all can, if you will, center around to be able to move closer to. We won't ever be in a position where we see everything the same way, but this very wide range of diversity of opinion is problematic for us. And so the closer we can get to a central truth about, as an example, what is disease, the better it will be for the entire ecosystem.
Nyree, if AI highlights variation between clinicians, do you have a process to convert that into mentorship rather than enforcement?
Yes, we do. So we have a number of different types of clinician within the estate. So we will have foundation dentists. We will have people who are first year post-qualification. We'll have mentees who come in from overseas. And we already have a well-established mentor program for them. And they say we already have our clinical development advisors. There is one for each small group of practices in an area, usually cover about 12, 15 practices. They have a very close relationship with all of their clinicians in their area. So they are already their mentor and they are the people who would step in to support in those scenarios.
I want to go on a little bit to ethics now, because that really becomes unavoidable when you're talking about AI. Gordon, with MHRA reforms accelerating, AI deployment in the UK is accelerating as well. Is regulation keeping pace with real world usage, do you think?
I don't think it is. And I think predominantly because the rate at which the technology is changing and the deployment speed moving faster every day, regulation is having a hard time currently keeping up. It's very similar in my mind to the concept of the self-driving cars. We have the technology for the cars, but the infrastructure to keep them on the roads isn't quite there yet. But what I've seen in both the US as well as the UK context is that the frameworks defining safety and classification are coming. Governance defining culture and usage as an example. In this case, compliance with these frameworks doesn't equal necessarily safe implementation. The real risk isn't necessarily regulatory lag, it's internal governance. In other words, how are we handling it internally within the individual deployments? The good news is These conversations are taking place at a much greater rate, including within organized dentistry, both here as well as across the pond. And I think that the initiatives to drive these conversations are becoming more and more important all the time. And I think that's something that we all have as a shared responsibility in organized dentistry.
If we come on to clinical harm, if harm occurs where both AI and clinician are involved, how should liability logically be distributed?
The way I would answer that is you can't sue your dental handpiece. AI is a tool. It's clearly just a tool. The responsibility remains with the licensed practitioner. I really don't think about it any different than a standard radiograph. Is the radiograph liable for an unfortunate outcome? Of course it's not. It's the practitioner. And I think that positioning artificial intelligence in this way makes the most sense. Now, vendors, however, like Overjet or any producer of AI, are responsible for algorithmic integrity and transparency around how the tooling is built. That's very important. Orgs are responsible for training and government. So you think about, as an example, MyDentist. And then at the end of the day, at the end of that base level, you and I and Dr. Whitley as clinicians are responsible for the care of the patient. I think about it as a shared ecosystem with each of us having distinct responsibilities.
If we go to the board level now, where do boards most dangerously misunderstand AI risk?
Two things. I think they either overestimate it, the fear of replacement, i.e. AI is going to come in and replace the dental hygienist and the dentist and the clinicians, or they underestimate behavioral risk. And what I mean by that, they look at assuming AI is a revenue lever, right, rather than a governance lever, as an example. It reveals variation, and it does it very well. I say oftentimes, AI forces me to look in the mirror. Now, in the morning, because I'm older, I don't like to look in the mirror sometimes, but I actually have to do that, right? It can make some people uncomfortable. If an executive board, as an example, treats AI as a growth hack purely for an ROI, they're really going to miss the structural value that's inherent in this type of technology.
You make a really important point, because with AI, I think the journey to actually implementing AI means you need to structure your data. You have to have processes and systems and governance in place. So even if an organization isn't quite ready to deploy AI, even being on that journey is just going to improve the organization overall. And ultimately, governance is only really meaningful if the economics do work underlying that. So let's move on to the financial layer. Nyree, AI won't fix broken economics, but as Gordon alluded to, they may expose them. In an NHS constrained system, does AI increase throughput or simply optimize within capped structures?
I think we'll just optimize. It's not going to increase throughput because you're going to diagnose whatever decay is there, and then it's up to the clinician to diagnose in the first instance, but actually just to decide how you're going to approach that disease, how you're going to stabilize the patient first, and then you're going to look at clearly get them out of pain if they have any, then the periodontal. That is how we were taught back at dental school, and it wasn't ascribed to any particular system, NHS or private, so it's not going to change that. So actually, in terms of throughput, it should make us more efficient in terms of having the confidence of being able to treatment plan, but it shouldn't change how we treatment plan things.
Do you think AI can narrow the digital divide between NHS heavy and private heavy practices?
It's difficult. One thing that I still hear both within our estate and external to MyDentist is people saying, I'm an NHS dentist. It drives me mad because you didn't do a BDS that said you're going to be an NHS dentist at the end, and somebody else did a different one that said they're going to be private. You are a clinician. You are a dentist. I think by giving clinicians additional tools such as AI, which they see as, wow, it's like intraoral scanners, it's super techy. They were only thought of previously as the reserve for private practitioners. I think it gives clinicians more confidence to offer patients those private alternatives and to have more confidence in their treatment planning processes and their ability to offer patients the full spectrum of treatment. Because what we talk to our clinicians about is, one, you are a dentist. It is your obligation to offer patients all of the treatment options possible. If you are not confident to deliver all those options, that's fine. You can refer them on to colleagues, and or we can take you on a journey for particular things if you wish, to be able to give you the skills to actually develop your career to be able to offer them.
And if we talk a little bit about governance now, what governance documents should every practice have in place before adopting AI? And I appreciate it's different when you're speaking of a large DSO or a single practice, but in your case, what governance had to be in place?
Oh, wow, so much. It has been a real journey, and particularly for Overjet as well. And Gordon can comment, because clearly we are their first big foray into the UK, and we have a significant amount of NHS contract that we deliver in our business. And there are very big governance and legislatory requirements around the NHS, which is one of the first things that we had to put in place. Then there are all the kind of pen testing side of things. Then there is clearly, what is very important is actually about the use of the patient's data. So it's the whole GDPR piece that you need to get in place, and effectively to have consent to be able to allow the AI to utilize that patient's data. But that was a big piece of planning over months and months, wasn't it?
Yes, it really was. And I think that the instruction there and the learnings are very important, because I think that with AI deploying ultimately around the world and society, we are going to have different environments that we're operating in. And I think that we need to understand the difference in environments. And what I have learned from this journey, if you will, so far, is that the learnings that we are taking from the UK and ultimately the EU will and can be applied to work in the US more in a collaborative fashion. And then I think if you think about long-term down the road, what does that look like for society globally, right? And we're going to hopefully come to some more centric view about how we look at artificial intelligence through the lens of society at large, as opposed to individual geographic regions.
We even went down to the minutiae in terms of speaking to the indemnity providers to give the clinicians the confidence to know that they were okay to utilize AI. So it's even little things like that. You need to have all of that infrastructure in place before you even start to implement it into the practices.
It's interesting to me that even going on this AI journey, it has such a multifaceted effect on all areas: the governance, risk, data. And it's almost forcing the profession to consolidate and standardize everything, that even if they don't deploy an AI tool, they're going to be better off. Patients are going to be ultimately better off. Mm-hmm. I think that's quite an interesting, perhaps unintended consequences of AI coming in. I want to talk a little bit about the data perspective. So from the enterprise data perspective, what pattern in large data sets has most surprised you?
Randeep, it's amazing what we're learning. And I think that's the beauty in big data, right? We learn insights from it and things that can make us better. I think the biggest one has been around variation, and it's much, much wider than most dental leaders assume it to be. In other words, the gap in opinion between dentist 1 and dentist 2 is tremendous. Not malicious variation in any way, right? It's different training backgrounds, how we're trained, our philosophy, our experience levels, and Nyree mentioned comfort thresholds as well. That comes to play in a dental assessment as well. Now, the AI doesn't really create that variation, but it does quantify it. It brings it to light, if you will. It surfaces it. And I think that transparency around it is really economically and culturally disruptive. It's the concept of who moved my cheese. I'm not sure I really want to look at this. As I mentioned before, I look in the mirror. Some days I don't like what I see, but I think it forces us to look directly in that mirror and then to take an introspective look about, have we been doing as well as we could do in our provision of dental care? And I think that is a really good thing.
In terms of the business side of things, does AI genuinely protect or grow EBITDA, or is that narrative just overstated?
I think it does, but I think it's indirect, actually, Randeep. It does not create revenue, but it certainly reduces leakage. I oftentimes tell clinicians when I'm speaking to them directly, it doesn't help you create more dentistry, right? But what it's really good at doing is uncovering the dentistry that exists within your patient population, and then allowing you to act upon that. So the goal here is not to treat more dental disease than is there. And it certainly is not to treat less. It's to treat the right amount of dental disease that we can now know through data exists within the populations.
I think the other thing to add there, it's around the patient education piece again. So it's around conversion, if you like. That sounds as though you're trying just to upsell, but it's not. It's about getting people to understand their disease and to better buy into treatment that's required, but also the prevention that they will need to undertake in order to not have any further disease.
Do you think AI makes corporate dentistry structurally stronger than independence, or does it level the playing field?
I think in the short term, the corporates can benefit from it because they really understand scaling governance, right? More so than a private small practice would. Long term, I think it really levels the playing field for everybody. Think about a single practice as an example with a good governance structure and disciplined use. They can achieve the same diagnostic consistency as a DSO that has 600 offices. AI democratizes the expertise if we use it correctly, and that's the key if we use it correctly.
I think that is the key, and I guess the reassurance around utilising something like this within a DSO is that there is the infrastructure that sits behind it to ensure that all the correct governance is in place, that you'll be appropriately trained, that there are people that you can talk to if you need any further support. If you're in an independent practice, I've worked in many, some I had amazing principals who are super supportive, others slightly less. And it would be the same with any kind of tool that is within that practice in terms of the amount of support that you got, and actually have they put the right infrastructure to sit behind it to know that you're using that in an appropriate way with patients.
I just want to zoom out a little bit. And this, I guess, is a question for both of you. If we fast forward 5 years and AI is embedded everywhere, what behavior in dentistry disappears completely?
I don't know. I don't think different behaviours to disappear altogether. The variability will probably reduce, but it is still down to the decision ultimately of those treating clinicians. We are never going to get 100% of clinicians agreeing with 100% of the AI because they shouldn't. They really shouldn't.
I would agree. And I think I would add that the concept of opacity is something that is a problem in human interactions, right? Where we don't really know what the truth is. I think AI has the ability to help us center around a more common truth. And I think overall, if you could apply that to any industry or any space, if you will, that is a good thing. So I think it will maybe dull this era of, I just see it differently, without some sense of objective discussion and objective explanation.
I always find this area fascinating because I always think that behavioral shifts are often the real story behind the software. But let's end at the horizon now. So if we look back in 2035, will this partnership present a technology upgrade, or do you think it will be the beginning of a new operating model for dentistry?
I think that ultimately this is a new operating model. And I really think the big picture here is that AI is a technology that's transformative. In fact, it's more transformative than anything that society has seen before by orders of magnitude. So there is change management that's required. There is cultural shift and cultural change that occurs. But I think that although there are bumps in any road of change, that at the end of that road, the further we go down it, the better our outputs are. And at the end of the day, for us as clinicians, as clinical oral health providers, that's what our North Star is. It's about better patient care and better patient outcomes.
Yeah, there has been an exponential change, hasn't there, in terms of tech and its involvement in dentistry over the last 5, 10, certainly last 5 years. Yeah. You cannot really comprehend. I don't think many associates now would go and work in a practice where they still have paper records and kind of wet films and not digital films. I think it is the same with AI, with scanners, certainly where we are trying to attract new clinicians into our business. A number of them will not even consider the positions if there's not a scanner in practice. And that's rightly so. I definitely think it's a much bigger operational change within the profession.
I always like to do a little lightning round. So these are quick fire questions. Nyree, we'll kick off with you. Okay. What's one red flag that tells you an organization is AI exposed, not AI ready?
Data, it's just not knowing where their data is stored and how it's utilized. That's a massive red flag. It needs to be secure.
And what's one diagnostic habit AI will permanently improve and one it must never replace?
It's going to permanently improve confidence, but it should never replace a clinician's autonomy to make a decision, the ultimate decision.
Gordon, one metric that will define the highest performing DSOs by 2030.
I'm going to call this one the DCI, the Diagnostic Consistency Index. I like that one. I think that increasing consistency of assessment between clinicians, inter-clinician agreement, if you will, is going to be one that's going to be very strong for us.
Is this a term that you've coined?
I made that up, but I think it sounded good, but I think it gets to the point, right?
You heard it here first. And Gordon, one AI promise that you think will fail?
AI will even in part replace dentists. That will clearly fail.
This conversation has really moved us from the chair side to the boardroom and back again. I think what's clear is that AI really isn't a feature layer. It's becoming operating infrastructure. Nyree, Gordon, this has been a really rigorous and honest discussion. Thank you for that. Where can our listeners connect with both of you?
LinkedIn is probably the easiest way. Just search up Nyree Whitley and then I'll have a profile on there.
Same here. We're all on LinkedIn.
To our listeners, TechDental only exists because of you. Your support, your feedback, your questions, they shape this platform and push the conversation forward. If this episode has challenged your thinking, share it. If it sparked an idea, pass it on. And if you believe dentistry is entering a defining decade, make sure you're subscribed. Join me next week for another front row seat as we decode the systems, the strategy, and the shifts shaping the future of our industry. Until then, stay curious, stay critical, and keep building. You've been listening to the TechDental podcast, Strategic Intelligence for Dental Leaders Navigating Structural Change. If you're responsible for growth, performance, or long-term value in this industry, make sure you're subscribed. I'm your host, Dr. Randeep. We'll see you next week.